Pancreatic neuroendocrine tumors are not the same as pancreatic adenocarcinoma. Hello, this evidence-based content is prepared by Saboor Khan, fellowship-trained consultant surgeon, and if you or someone you care about has just heard the words pancreatic tumor, you're probably feeling overwhelmed right now. I know those words can be terrifying, but here's something critically important. Not all pancreatic tumors are the same disease. Today we're going to explain the vast biological and prognostic differences between the common pancreatic ductal adenocarcinoma, that aggressive cancer you've likely heard about, and the rarer pancreatic neuroendocrine tumors, or PNETs. Before we dive into the differences, let's establish what we're dealing with. Your pancreas is actually two organs in one. More than 95% of malignant pancreatic tumors arise from the exocrine elements, the ductal cells that make digestive enzymes. This is pancreatic ductal adenocarcinoma, representing approximately 85% of all pancreatic neoplasms. But neoplasms arising from the endocrine pancreas, the islet cells that produce hormones like insulin and glucagon, comprise no more than 5% of pancreatic tumors. Pancreatic ductal adenocarcinoma is one of the most aggressive cancers known to medicine. It arises from the pancreatic duct cells, grows rapidly, and spreads early. In contrast, pancreatic neuroendocrine tumors develop from the hormone-producing islet cells scattered throughout your pancreas. PNETs are typically highly vascular, meaning they have rich blood supply, with enhancement in the early arterial phase on CT scans and washout in the early portal venous phase. While adenocarcinomas are almost uniformly aggressive with poor prognosis, regardless of subtype, well-differentiated pancreatic neuroendocrine tumors can be essentially benign lesions when they're small. Pancreatic neuroendocrine tumors less than 0.5 centimeters, called microadenomas, are essentially benign. Most surgically resected PNETs between 0.5 and 1 centimeter, that's about the size of a small grape, are cured with resection, and further surveillance isn't even indicated. The most common presenting symptoms in patients with exocrine pancreatic adenocarcinoma are pain, jaundice, that yellowing of the skin, and weight loss. In one observational series of 185 patients, the most frequent symptoms were asthenia, or extreme tiredness, in 86% weight loss and 85% anorexia, or loss of appetite, in 83% abdominal pain in 79%, and jaundice in 56%. These symptoms typically appear late in the disease course. PNETs can be functional, meaning they secrete hormones causing specific symptoms, or non-functional. The critical point is this: PNETs are often detected much earlier, sometimes incidentally during imaging for other reasons, or through screening programs in high-risk individuals. Well-differentiated pancreatic neuroendocrine tumors have been detected within familial pancreatic cancer screening programs, often before they cause any symptoms at all. For pancreatic ductal adenocarcinoma, only 15 to 20% of cases are potentially resectable at presentation. Even for those undergoing microscopically complete resection, prognosis remains poor. 5-year survival after pancreatic duodenectomy, that's the Whipple procedure, is only approximately 10% for node-positive disease, even if only one lymph node is positive, while it's approximately 30% for node-negative disease. The median survival for various stages ranges from 14 to 38 months. Most surgically resected pancreatic neuroendocrine tumors between 0.5 and 1 centimeter are cured with resection. The TNM staging system used for all pancreatic cancers, both exocrine and neuroendocrine, is the same 8th edition system, but outcomes differ dramatically. If you're supporting a loved one with a PNET diagnosis, here's the reassuring context. These tumors, particularly when well-differentiated and caught early, offer hope for long-term survival and even cure. For pancreatic adenocarcinoma, surgical resection offers the only chance of cure, but the high rates of both systemic recurrence, greater than 80%, and local recurrence, greater than 20%, after surgery alone, mean that systemic chemotherapy, radiation therapy, and combined approaches are standard. The extent of surgery for adenocarcinoma, whether partial versus total pancreatectomy, is driven by the extent of disease, with multidisciplinary individualized decision-making highly recommended. For pancreatic neuroendocrine tumors, the approach is more nuanced. The extent of surgery is driven by the extent of disease, including multifocality of lesions, location of the dominant lesion, and the patient's life expectancy and overall health considered with the risks and benefits of the type of surgery. Here's the key difference. Small, well-differentiated PNETs may not require the aggressive perioperative chemotherapy that's standard for adenocarcinoma. First, get precise pathological classification. If you or a loved one has been told about a pancreatic tumor, insist on knowing whether it's ductal adenocarcinoma or a neuroendocrine tumor. This isn't splitting hairs. It's fundamentally different diseases requiring different treatment approaches. The tissue diagnosis should specify whether it's exocrine pancreatic cancer or a neuroendocrine tumor, and for PNETs, whether it's well-differentiated. Second, if you're at high risk for pancreatic disease based on family history or genetic predisposition syndromes, understand that screening can detect predominantly asymptomatic early pancreatic neoplasms, including PNETs, at a time when they're potentially curable. Screening is recommended for specific high-risk groups, including patients with Peutz-Jeghers syndrome, regardless of family history, those with certain genetic mutations, and familial pancreatic cancer kindreds. Third, if imaging has been done, ask specifically about the enhancement pattern. Pancreatic neuroendocrine tumors are typically highly vascular, with enhancement in the early arterial phase and washout in the early portal venous phase. These are specific scan-related findings. The red arrow points to a bright pancreatic neuroendocrine tumor. This imaging characteristic on CT can help distinguish PNETs from adenocarcinoma even before biopsy. Ask about staging using the 8th edition TNM staging system. While the same staging system applies to both exocrine and neuroendocrine, pancreatic cancer's outcomes differ dramatically by tumor type. You need to know not just the stage, but how that stage specifically relates to prognosis for your tumor type. Discuss surgical options in detail. For well-differentiated PNETs less than 1 centimeter, ask whether complete surgical resection alone might be curative, without needing additional chemotherapy or radiation. Sample question. Given the size and differentiation of this neuroendocrine tumor, what are the chances of cure with surgery alone? For adenocarcinoma, ask about neoadjuvant therapy. Sample question. Would chemotherapy before surgery give me a better chance at complete tumor removal? Ask about multidisciplinary tumor board review. Both conditions benefit from evaluation by teams including surgical oncologists, medical oncologists, radiation oncologists, and radiologists. This isn't optional. It's essential for optimal outcomes. Seek urgent evaluation if you develop new jaundice, that yellowing of skin or eyes, particularly if accompanied by dark urine, light-colored stools, or itching. While this is more common with adenocarcinoma, particularly tumors in the head of the pancreas, it requires immediate assessment. If you have unexplained weight loss, more than 5% of body weight over 6 months, combined with upper abdominal pain radiating to the back, this warrants urgent pancreatic imaging. For those with familial risk factors or genetic predisposition syndromes, new-onset diabetes may be indicative of an underlying pancreatic neoplasm. Urgent imaging should be performed within 2 weeks with endoscopic ultrasound MRCP or pancreatic protocol CT scan. If you're experiencing symptoms that might suggest functional PNETs such as recurrent low blood sugar episodes or severe diarrhea, discuss pancreatic neuroendocrine tumor evaluation with your physician. Pancreatic neuroendocrine tumors and pancreatic ductal adenocarcinoma are fundamentally different diseases, requiring different treatment approaches and carrying vastly different prognoses. Your next step. If facing a pancreatic tumor diagnosis, ensure you have precise pathological classification distinguishing adenocarcinoma from neuroendocrine tumors. This information is for education. Always discuss your individual situation with your healthcare provider. I've outlined several reputable resources here, which you may find valuable for further information on this topic. All links are available in the description below. Thank you for watching.